Hi, I'm Andy Rosenkrantz, the editor-in-chief of AJR, and I'm here today with Dr. Natally Horvat, an assistant attending radiologist at Memorial Sloan Kettering Cancer Center, and she'll be discussing her recently published AJR article, Mucinous Degeneration on MRI after Neoadjuvant Therapy in Patients with Rectal Adenocarcinoma, Frequency and Association with Clinical Outcomes. Dr. Horvat, thank you for joining us.
Hello, thank you so much for inviting us to present our paper here. In name of the authors, I will be glad to talk to you about our results and our method. Thank you for inviting us.
Great. So to start off, please summarize for us the prior literature regarding the association of mucinous degeneration of rectal cancer and outcomes.
Yeah, so the first data regarding mucinous degeneration started not in rectal cancer, but in esophageal cancer. So the first papers in rectal cancers, they tried to conclude that this is a kind of pathological complete response. But immediately after that, the other papers showed that actually it's a type of response, but not necessarily associated with complete response. And in terms of outcomes, there was mixed results in terms of literature. Some papers showed better outcomes and some other papers showed no difference in terms of outcomes.
Great. So next, could you summarize for us, for your present study, the patients who formed the study sample?
Yeah, so we included consecutive patients who underwent baseline rectal MRI and restaging rectal MRI after neoadjuvant therapy. And all those patients underwent total mesorectal excision after neoadjuvant therapy.
Okay. So the radiologists who participated in this study, they reviewed the MRI examinations for certain categories relating to the tumor's mucin content. And there were two components to that. The first piece was categorizing just individual examinations at baseline and restaging. So could you explain how that worked?
Yeah, so the way that we use on imaging to call a tumor as a mucinous tumor is based on the amount of mucin within the tumor itself. So we use the same criteria as the pathology. So after 50%, we call it a mucinous tumor. So knowing that, we split our sample size, we split our analysis in baseline scan and restaging scans. So for both of them, we categorized the mucin content and percentage. But in the end, we split into less than 50% or more than 50 in order to separately mention that if that tumor or tumor bed, we have mucinous tumor or not.
Great. So, and then once the individual examinations were categorized in that manner, you then combine that between the two examinations to assign patients to an overall mucin status. So how did that work?
Exactly. So we after that, we created 3 different groups of patients. Non-mucinous tumors, the majority of them, which means less than 50% of mucin on baseline and restaging scans. The second group, mucinous tumor, patients with mucin, more than 50% of mucin with high signal intensity on T2. On both restaging and baseline scan. And the third group called mucinous degeneration, based on baseline scan without mucin, like less than 50%, and restaging with more than 50% of mucin.
Great. Okay, so then moving on to your actual findings, just what did you observe in terms of the frequency of these different mucin statuses?
Yeah, as expected, the non-mucinous tumor were the most frequent one, 78%, followed by mucinous tumor. And the less frequent group was the mucinous degeneration, around 5.5% of those patients.
Okay. So what was the association of the mucin status with pathologic findings?
Yeah, so when we compared the frequency of pathological complete response among the 3 groups, we didn't find any difference among those 3 groups. So even the mucinous degeneration after surgery, the part of the tumor with mucin didn't show cellular mucin, but surrounding the mucin lakes, the pathologists found viable tumor cells.
Okay. And what was the association with patient outcomes?
In terms of patients' outcomes, different from other papers published, all the 3 groups of mucin status had similar endpoints in terms of recurrence and overall survival, all of those 3 groups of patients.
Yeah, and I thought that was actually really well shown. So there was an adjusted regression model where you control for many factors: patient age, sex, T and N category, surgical approach, EMBI, the resection margin, lymph nodes. So really did look at that rigorously, and it seems like you made a strong case here.
Yeah, and the number of patients with mucinous degeneration was not that big, but we tried our best to adjust to possible confounders. So after that, we didn't find any association between the mucinous status and outcomes of those patients, which was quite surprising for us because we were expecting to have 3 different groups. The worst will be the mucins, the other one will be the non-mucinous, and the better one will be the mucinous degeneration. But in the end, we didn't find any difference.
Oh. Are there any major limitations that are important for our listeners?
The major one is that although we did a radiological assessment among 2 different readers, the pathological assessment was done by only 1 pathologist, and we didn't correlate with the whole amount pathology. So it was not possible to have exactly point-by-point correlation between imaging and pathology, but we did our best to ask our pathologist to reveal the case, especially the one with mucinous degeneration, in order to make sure if we were able, if she was able to find tumor cells within the tumor bed or not.
Okay. So given that the mucin status was not associated with these various outcomes that were looked at, what else should be explored to help guide management in these patients?
Yeah, that's a very good question. Like answering our aim of this paper, or what we want to conclude is that in the scenario of mucinous degeneration, we cannot conclude as complete response because those patients can still have viable tumor there. But trying to think about the future, since those 3 groups of patients, they had similar outcomes, especially when we are thinking about mucinous tumors. If the patients are having good outcomes, probably because of improvements in the neoadjuvant therapy, it's worth for us to try to explore other ways to try to evaluate mucinous tumor after neoadjuvant therapy in order to differentiate cellular from acellular mucin. Because the way that we are doing now, we are concluding if we are dealing with a mucinous tumor, in the restaging, we put MRI cannot distinguish between cellular and acellular mucin. But there is an increasing growth of watch and wait approach. So the surgeons and the oncologists, they are keeping asking us, what should we do with those patients, especially patients with low rectal tumor? So this is a kind of hope for us to keep trying to find other ways in order to better select the patients for watch and wait approach.
All right. And do you have a final takeaway or parting message for our listeners?
I think that the main takeaway here is try to look into the tumor, try to define the mucinous status, but don't be very worried about that because in the end, it seems that the outcome is the same, but especially don't think that if after treatment, if you see mucin, don't feel comfortable in saying that there is no tumor left, and forget about the mucin content for a while and search around the mucin lakes, because probably you will be able to see some viable tumors there.
Dr. Horvat, I really appreciate your coming here and sharing your insights with us. Thank you.
Thank you so much. It was a great pleasure.